Merci. Merci, Alain, and thank you, Florent, and the whole society for inviting me. That was a lovely introduction. I wish I could speak to you in French. In fact, I have a French exam later this month, but I don't think I will get the B1 level. If I do get B1, then through my marriage I can become French, which would be great. It would be great to rejoin the European Union, but I think I'm going to fail the exam because I've been too busy. But maybe in a couple of years' time I can speak to you in French. But this is my only French slide, my conflicts of interest, but I have it in English as well, so these are my conflicts. Let me start with some art. Every time I visit Paris, I try and go to one of your amazing art museums. And in London, we have a medical art museum, which is funded by the Wellcome Trust. This is a previous installation, actually, in a room with the ceilings about this size. And you can see a huge bookcase with really big books, numbered 1111 all the way up to 22. And some of the books are open, and when you look more closely at the books, you can see all of the characters in the book as either A, C, G, or T. So they're very boring books, but let's just zoom out. This is one human person's DNA code printed out. So that is the DNA code. It's basically just 3 billion letters, A, C, G, or T. And I still find this amazing, that if you go to one point in these 3 billion letters and say it's a C there, and it changes to, say, an A, that one change could be enough to cause some diseases, like cystic fibrosis can be caused by one change, sickle cell anemia, and there are some types of glaucoma that we look after that are caused by one change. And in adults, the most common one is one change in the myocilin gene. And that's called simple or Mendelian glaucoma. In this talk, I'm not going to go into that type of glaucoma. We don't have time. I'm going to focus on the more common type of glaucoma, which is complex. And in a complex disease, each individual risk factor on its own doesn't cause the disease, but when you have enough of them, cumulatively, a threshold is reached and it's caused disease. And each one of these risk factors, each one of these arrows, can be a common genetic variant across the whole of the genetic code. And so most of the glaucoma you look after, over 95% that you look after in your clinic, is this type, the complex type. Now, because you're looking for common variations that each don't cause the disease, it makes identifying each individual one quite complex. So what's changed? Well, one thing that's changed is how cheap it is to now measure the genetic code. It's so cheap, you can get it in your local high street pharmacy. Unfortunately, 23andMe now aren't doing so well. If you could think of it, that they're going bankrupt, but you could also think of it as an opportunity. It's now so cheap. You can now get the genetic testing even for £79, less than €100 to get this genetic testing. And that testing on its own will give you all of the data you need for yourself for everything else I'm going to show you in this presentation. So with it becoming so cheap, it means we could do the tests on big populations. And we do something called genome-wide association study. And when you do that, you can summarize all of the results into one graph. Now, I don't know, can you see my arrow? Yes. So this graph, on the x-axis, you start from the beginning, page 1 of book 1 on that bookcase, all the way up to the end, last page on book 22, and you go through the whole of all of the letters, but only the letters at which we vary as humans. Then each dot here is one point in that bookcase where we vary, and how high up the point is how that variation is different between glaucoma and control. So the higher up the dot, the more significantly there's a difference at that genetic variant it associates with the risk of glaucoma. Now, because you're doing so many tests, you can't have a p-value less than 0.05. You have to have a p-value at this point, which is 5 times 10 to the power minus 8. And if you got a point above that, then that means it's significant. Now, this is back in 2016. This was putting together all of the data at that point for studies that had glaucoma case control and genetic data. And we were so excited. Wow, 9 points of the DNA code that was significant. And this was teaching us a bit about the biology. We could say, what does this gene do? What does this gene do? But the problem is, glaucoma is so complex that knowing only 9 points on the genetic code, which contribute to the risk, wasn't enough for us to understand the disease or to be able to predict the disease from the genetic code. So the big change came from the big studies, and in particular UK Biobank. This is, in total, it's got 500,000 people, but we're really lucky that through the lobbying efforts of Professor Serpencourt and Paul Foster at Moorfields and UCL, they were persuaded to include eyes in UK Biobank. So in around 100,000 people, there are eye measurements as well, including intraocular pressure and details about glaucoma measurement. So with this bigger study, what does the result of the genome-wide association study look like now? And it was transformed. This was a really big step change. This 5 times 10 to the power minus 8 p-value is now all the way down here, and look how many points in the genetic code are significant. In fact, these plots are called Manhattan plots, and now it looks a lot more like Manhattan with so many skyscrapers. Over 100 of them, and each of these points you can consider one of these causes of glaucoma. So if you have more of these genetic variants, the more likely you are to have glaucoma. The good news is you don't have to understand those plots. All you need to know is that you can summarize that plot into one number. And if all of you did your cheap genetic testing, I could work out that one number in you, and it's got a normal distribution, a bit like height or anything like that, and we call it the polygenic risk score. Now that number will then tell you your individual risk for glaucoma. And this was the first time it was kind of shown so strongly. This was in an Australian study, and in the top 10% of that genetic risk score, there was 15 times the glaucoma than in the bottom 10%. So we could do that in this room. If you all had genetic testing, I could identify 10% of you compared to the other percent where you're going to have 15 times the glaucoma. And that's ignoring any other factors such as age and any measurements. We could do that from the moment you're born, without even measuring IOP or doing an OCT or anything like that. Now that isn't diagnostic. You can't, on the basis of just your genetic code, diagnose glaucoma. All you can do is work out a subset that are much higher risk. Why is that important? Well, we don't need reminding that with glaucoma we have a disease that people don't realize they have it at the beginning. They're asymptomatic. By the time they get the disease, it's too late because the damage is irreversible. And we have plenty of treatments that work, yet we don't screen for it. Anyone outside of ophthalmology says, well, why don't you screen for this disease? If you have treatments, and early diagnosis makes a difference. This is the problem. That, let's say you take 50-year-olds, the prevalence of undiagnosed glaucoma is quite low. So even if you've got a good screening test that's quite sensitive and quite specific, nearly 90% of the people you'll be sending to the hospital won't actually have the disease. And that can't be cost effective. But let's imagine this future where everybody has their genetic testing done. For example here, if you then apply the very same test to the top 10% of the polygenic risk score, the same test does much better, and nearly half the people you'll send to the hospital will have the disease. So this is the hypothesis, and Alain alluded to something we'll be testing through the European Glaucoma Society. Now, all the data I've shown you so far comes from just people of European ancestry, just white people. So if we are going to find a new way to detect glaucoma, enable glaucoma screening, we need to make sure it works in people of all ancestries. And this has always been a major concern with genetic studies. But actually we needn't be so concerned, using newer methods, we're getting there, but actually even using the old methods, and I love this paper recently out, taking a polygenic risk score we made just using European data and then applying it to different African populations. I think mainly Anglophone, actually. We still need to go and do it in Francophone African nations, but it does well, even though it was designed for Europeans. And there are now methods where you can design it to work cross-ancestry. But it works well, and here the samples weren't large enough to do top 10%. So even in the top 20%, you're really seeing an enriched subset. So the concerns that this might not work in non-Europeans, I'm less worried about. We obviously still need more work. We need larger studies in people of non-European ancestry, but looks as though we're getting there already. One other thing is public acceptability. Do people want to know their risk of glaucoma? Now, we were talking about this just before this session. We were saying, say, for dementia, Alzheimer's disease, maybe you don't want to know the risk because there aren't really any acceptable treatments, things to do about it. But for glaucoma, we've got acceptable treatments. The screening test is non-invasive. You just have your pressure checked, your OCT taken maybe. And actually, when we ask patients and relatives of patients, they seem very open to having a genetic test to help them being diagnosed early. What hasn't really been done is asking the general public, though, healthy people, what do you think about knowing your risk of glaucoma? And if we tell you you're at high risk, you may never develop the disease. What do they think? And that's still something we need to do. Another big problem with screening are these biases. The famous one, for example, in cancer, this lead time bias. If just because the cancer, let's say breast cancer, is diagnosed 5 years earlier and the patient lives 5 years longer, maybe they haven't actually died at a later age. It just looks as though it was longer since the cancer diagnosis just because it was picked up earlier. You haven't actually altered the final outcome. Is it the same with glaucoma? If you start treatment a few years earlier, is there actually going to be less chance of blindness? We don't know that answer. And to do that, really, and to persuade the payers of healthcare, we're going to have to do a randomized controlled trial. And that's really where the European Glaucoma Society screening task force is driving us towards. And it's complex, and there are multiple different elements to it, not just genetics. Of course, AI, understanding the natural history, the health economics, the public acceptance, and finally designing this randomized controlled trial. Anyway, we don't think genetics is going to be just helpful for detection, just helpful for risk stratification in the general population. It's also teaching us about biology. And one exciting thing you can do when the genetic results are so dense, there are so many very statistical significant signals, is you can look for patterns in it. Are there any of the genes that these signals are at that work together in pathways? And there were many significant pathways, but the number one, which is the only one I'll share with you today, was for angiogenesis. And I thought this was so strange when the result was coming out. I thought I must have made a mistake in the code. We do surgery in trabecular meshwork. We know the histology of it. There aren't blood vessels there. Why is angiogenesis coming up so strongly? And then when looking at the genes that were mainly driving it, it started to become clear. It wasn't blood vessel genesis, it was lymphatic vessels, lymphangiogenesis. And we're learning more and more now that Schlem's canal, which even though it's very near trabecular meshwork, is a different embryological origin and is a completely different tissue type. Schlem's canal and collector channels are actually lymphatic vessels. And this top picture is a normal Schlem's canal in a mouse. If you knock out this lymphangiogenesis pathway, you get no Schlem's canal and yet a normal trabecular meshwork. So the number one biological pathway for intraocular pressure and glaucoma in adults has got nothing to do with trabecular meshwork and is all Schlem's canal and collector channels. So that challenges this dogma that POAG is a disease at trabecular meshwork, And no wonder then some of our treatments which target trabecular meshwork don't work in everybody, because their problem may well be beyond that. And one typical treatment that we use increasingly commonly to target trabecular meshwork is selective laser trabeculoplasty, SLT. And we know, we've looked at the real-world data, that if all our patients were the same, they'd have this excellent reduction in intraocular pressure that slowly wanes over time. But our patients aren't all the same. They're individuals. And these are the treatment responses to selective laser trabeculoplasty. Some patients do amazingly well. A few get worse. And then there's this whole range in between. And why is this? Why is it some people don't respond? Could it be that their problem was never at trabecular meshwork? It was beyond that. So the question's been, for me, for a while, can these genetic variants, or can a polygenic risk score for this lymphangiogenesis predict response to selective laser trabeculoplasty? And I'm pleased to say that we presented our first results of this just earlier this week in ARVO, one of my current PhD students, Richie, and these are the results. So we made a polygenic risk score for lymphangiogenesis. So this is a risk score saying how likely is it that you have a problem in your Schlemm's canal and collector channels. And the people that had a higher problem in that were more likely to fail their SLT than people who had a low score on it. And this is data from the LIGHT trial. So we genotyped the samples for the participants of the LIGHT trial. So exciting results, and maybe in the future you could see that knowing this genetic data, having this genetic data available, might help you decide who to do SLT on and who to do drops on. Let's switch gears a bit and think about modifiable risk factors for glaucoma. So let's go back to that question. Do you want to know your future risk of glaucoma, your genetic risk? Would you like to know it? If you do you want to know the things that you can do in your life to reduce that risk? You should. We want to empower our patients to do that. But up until recently, looking at these modifiable risk factors has been not straightforward in glaucoma, and very rarely any consistent results. But now, with larger studies and understanding the genetics, we revisited this. The first thing we looked at in our collaboration was caffeine, because it's something all of the investigators really enjoy. In UK Biobank, the big study, we asked people about how much coffee and tea do they drink and which type. And I just want to show you this, just so that you show that the UK people are true to our reputation. We do love tea. And you can see we drink much more tea than we do coffee. And quite crazily, nearly 1 in 5 people in the UK Biobank drink 6 or more cups of tea a day, which is quite a lot. But actually, not everybody consumes their caffeine through tea or coffee. France, as you could probably imagine, is a coffee drinking nation. But look at Spain and Portugal. Even Italy get most of their caffeine through soft drinks. And actually, it's not just drinks. We get a lot of caffeine from other types of food as well. So fortunately, in UK Biobank, they sent people these email questionnaires about what food and drinks they consumed in the previous 24 hours, and repeated this. And together with a nutritional epidemiologist and looking up food tables for the UK, considering 19 questions on different caffeine-containing foods and beverages, we could make one number for the average caffeine consumption for each person in UK Biobank. So we looked at that for the intraocular pressure, the corneal compensated intraocular pressure, and dividing people into 5 equal groups of intake. If anything, we found that higher levels of caffeine intake were associated with a slightly lower intraocular pressure, which was counter to what we thought. We know in some studies of glaucoma sufferers, when they consume caffeine, the intraocular pressure increases a bit. So not much there. And when we looked for glaucoma prevalence overall, we found nothing. No trend at all. Now, in years gone by, we would have stopped there. And probably the conclusion would be, it's okay, you can drink coffee, you can drink tea. But actually, now we understand glaucoma is such a genetic disease, we decided to take into account the genetic predisposition. You would never do a study in glaucoma like in that caffeine and not adjust for age, because age is such a strong risk factor, you have to adjust for it. Actually now, the polygenic risk score for glaucoma is just as important as age, and so you need to take that into account. And that's what we've done here. So this graph is caffeine intake versus IOP, but it's separated into 4 groups, which are the different polygenic risk scores. You can see the people in the top polygenic risk score here have a much higher IOP than the bottom one, but also they've got this significant slope. And in epidemiological size, this is actually quite a significant slope. And that's called a gene-environment interaction, when, depending on your genetic score, caffeine may or may not be associated with higher intraocular pressure. And people in this field will know it's very hard to get a significant gene-environment interaction unless you've got very big studies. So this was an exciting result. And when you look at the prevalence of glaucoma as well, this only shoots up in those people at the highest quarter of genetic risk, a very significant gene-environment interaction. So caffeine may well be important for glaucoma, but only if you're genetically predisposed. And just to say on that, we believe caffeine affects the ciliary body. They have adenosine receptors on there and makes you produce more aqueous. Now, if genetically speaking, you've got a great aqueous outflow system, it's fine. Produce more aqueous, your eye pressure won't go up. If genetically speaking, you've got one that's going to start to fail around the age of 40, then produce more aqueous, your eye can't deal with it, the pressure goes up and it increases your risk of glaucoma. So that's the hypothesis. And we've since shown similar things for salt intake and alcohol intake with gene-environment interactions. So the higher your genetic risk, the more likely perhaps that alcohol intake and salt intake will increase your risk of developing glaucoma. But we didn't find anything for smoking or physical activity. And this is a growing area. Let's think about it the other way. So here we've thought about, well, does caffeine associate with glaucoma risk? Well, maybe genetics modifies whether caffeine associates with genetic risk. But what about the other way around? You've got a high genetic risk of glaucoma. Can caffeine intake or anything else reduce your risk, even if you're at high genetic risk? So this is in UK Biobank. This is the bottom 90% of genetic risk. This is the top 10% of genetic risk. If you're told you're on this red line, as you get older, wow, it's looking a bit scary for developing glaucoma. And this is separating out that line into alcohol intake, the top third, middle third, and bottom third. And it's making a bit of a difference, not a huge difference. But maybe in the future, if we mix together multiple behaviours, we can find a set of behaviours that can reduce your genetic risk. What about in the clinic, though? So far I've been mainly talking about risk of developing glaucoma in the general population. But what about this? I've already shown you some early results from ARVO that we might be able to predict who will respond to SLT. But what about this problem? These are David Crabb's famous moving dots. How each dot is moving is how each person's vision is worse, visual field's worsening in their right and left eyes. Basically, you don't want to end up in this bottom right-hand corner because it means you've become blind in both eyes despite treatment. The problem is, when we first see a patient, we're not very good at predicting who's going to end up there. So can genetics, can a polygenic risk score help us do that? Well, one really nice example is the ocular hypertension treatment study. We all know if you treat people with high pressure that haven't developed glaucoma yet, you reduce the risk of them developing glaucoma. But if you look at the people who weren't treated, still only 12% of them converted to glaucoma. So we shouldn't treat everybody with ocular hypertension, right? And none of us do. Whether you use some of these risk calculators that are available, or you just take into account the parameters, age, baseline IOP, central corneal thickness, and so on, we use them in our head, don't we, to decide who to treat. If someone's got a pressure of 23 and corneal thickness is above 600 and their cup disc ratio is 0.1, we're not going to treat that patient, are we? The question is, can genetics help us even more, do better than that risk calculator? And let's look at the number one gene for IOP and for glaucoma, TMCO1. They did that in the ocular hypertension treatment study. Those are the traditional factors. They added the genetic variant at TMCO1, and it was highly significant, with a hazard ratio of 1.73 per risk allele. Now, for me as an epidemiologist, I got very excited with that and trying to convince my clinical colleagues. I say, well, actually, if you've got both risk alleles, it means you're at a threefold increased risk. But still, my clinical colleagues don't look impressed. So then I say, what if I match this threefold risk to other factors that you have been using every day in your head to decide who to treat? It's like your patient being 33 years older or having a baseline cup disc ratio 0.43 larger, or a baseline IOP 12 millimeters of mercury higher. So quite stunning results that need replication, but give you an insight into how knowing the genetics might just, you all already are risk stratifying anyway. That's one of the main things we do as a doctor, but this might help you make better decisions. Now, that was one genetic variant. What about a polygenic risk score? Surely that should do much better. Well, they looked at this recently, a polygenic risk score in the OATS study, and these are the results. And if you're at a high polygenic risk score, you're more likely to convert than a low, but really not much of a difference here. This was a little bit of a disappointing finding. I was hoping it would be even stronger. And probably the issue here is the polygenic risk score isn't for conversion to glaucoma amongst people with ocular hypertension. It's for who's going to get glaucoma in the general population. So all the weights in the formula are probably not optimal, and we need to make the PRS better. We need a more intelligent approach. It's also, the PRS has been shown in some small studies to associate with treatment commencement or escalation, or visual field worsening despite treatment. But these are small studies and haven't really been replicated as yet. What we need is the UK Biobank moment for this type of data. We need progression data, response to treatment data in much larger data sets that have genetic data available. So I'm really excited to share that we are doing this. We've linked this exact sort of data that are used to make these two graphs with UK Biobank for over 60,000 of them. And they all have genetic data. Now, this data should be available by the end of the year, so I hope next year we'll be able to start to show you how the PRS, a different PRS, trained on this data, can help you in the clinic. But when is all of this feasible? I mentioned to you earlier, we can, if we had your genetic data available, we could target you for screening, but most of us don't have our genetic data available. Well, some of us who've done 23andMe have it available. This is my glaucoma polygenic risk score. Luckily, it's quite low. They, in fact, give you advice if you do have high polygenic risk to limit your caffeine consumption based on our study. Unfortunately, 23andMe are going bankrupt, and this would rely on you paying for it. Really, we need whole healthcare systems to do the genetic data for you, and that's happening in the UK. The Our Future Health Study already has funding to do this on 5 million UK adults. That's over 10% of the adult population. They've already recruited 2 million. So we're on the way in the UK, and I think eventually it would be the National Health Service that does this. How the business models will work in different countries, I'm not sure. I believe it's just our job to be ready for when that genetic data is available, that we use it not just for breast cancer and prostate cancer screening or for other more developed fields. I want us to be ready in the care of glaucoma to be able to use that immediately. So hopefully I've persuaded you that PRS, the polygenic risk score, would help us for screening of glaucoma, for identifying those at highest risk so we can treat them more intensively. Help us pick which is the right treatment that's going to work for your patient, rather than our current trial and error. Let's try laser, let's try drops, and so on. And I think it's also going to help us personalize the lifestyle advice we give our patients. Now, lastly, I just want to finish on showing that the thing with the polygenic risk score, it's already as important as age as a risk factor for glaucoma, but it's just getting better and better. So from that last study I showed you, there are so many more studies now across Europe and outside of Europe that have genetic data and glaucoma-related data. And so our studies get bigger. Now over 300,000 people now look at the Manhattan plot. There's now over 300 points on the genetic code, which is significant. And this means that, you know, if this is the overall risk of glaucoma, if you don't know about genetics, increasing with age, if you know about genetics and look at the top 10%, that's where it was, but that risk score has already got better just in a couple of years to that level, and it will continue getting better, we estimate, till we have studies of over 1 million people. So exciting and times ahead. For that last analysis, in fact, we escaped England, and this was in Albania. This is the research group that did it. We did a hackathon, an analysis sprint, and I'd just really like to say thank you to them. Without the team, we wouldn't be able to analyse such large data at scale so effectively. Thank you very much for your attention.